Antibiotics and endodontics. Who has not had a patient like this? The one that describes to you ever so precisely the exact symptoms of an irreversible pulpitis, starting with intermittent hot and cold sensitivity lasting seconds, followed by lingering pain, spontaneous pain, pain requiring analgesia, and then tenderness to biting. And then they say, my doctor, dentist, gave me an antibiotic, and now it's much better. We all know the guidelines, there for an important reason. The rate of antibiotic resistance in the general population is increasing. This trend is supported by multiple studies and surveillance data. It can be seen across various antibiotics, including phenoxymethylpenicillin, amoxicillin, and clindamycin. This trend underscores the need for stringent antibiotic stewardship and continuous surveillance to mitigate the spread of resistant strains. Now, clearly these guidelines were not read by whoever prescribed this patient an antibiotic for what was essentially an inflammatory condition, admittedly caused by bacteria in the caries that caused the pulpitis, but whose death would do little to mitigate the clinical situation. Ask the patient how long it took the antibiotic to work, and they'll frequently say, oh, at one point, I didn't think it was going to work at all. If an antibiotic is going to work, it will usually do so within 48 hours. The fact that it took 5 to 7 days proves that the antibiotic did nothing except provide the patient with the patience to sit out the pain because they had the high hope that it would get better, which it eventually did through pulp necrosis. Even when bacteria can be specifically involved, producing the toxins to create periapical or periradicular pathology, both the American Dental Association, the ADA, and the European Society of Endodontology, ESC, provide specific recommendations for the urgent management of pulp and periapical related dental pain and intraoral swelling. According to the ADA, antibiotics are generally not indicated for conditions such as symptomatic irreversible pulpitis, pulp necrosis, and localized acute apical abscess without systemic involvement. Indeed, the primary treatment should focus on achieving drainage through operative interventions like pulpotomy, pulpectomy, non-surgical root canal treatment, or incision and drainage. The ESC highlighted antibiotics should be reserved for cases with systemic involvement or prophylaxis in medically compromised patients. This makes perfect sense. The main population of bacteria will be within the root canal system and hardly accessible to the antibiotic within the circulating blood flow. In fact, I often wonder why they are so successful at damping down painful symptoms, when seemingly only a very small proportion of the bacteria will be wiped out. I rationalize this by considering an acute exacerbation of an endodontic infection to be like a periapical war zone in which the bacteria and their toxins have got the upper hand against the immune system. The body only requires a little bit of help, perhaps some drone strikes at particular targets to fight back and re-establish the status quo. Realistically, us wet-fingered dentists will understand the difficulty of a patient being booked into a 10-minute slot with severe pain and swelling, but without systemic involvement. Try and sort that out with a clinical intervention, Mr. ADA. Nonetheless, it's important that we consider the overall health of our patients and those of our future generations, and we do not prescribe antibiotics lightly. Certainly, when the vast majority of the bacteria will not be killed and have the opportunity to dine out on watered-down antibiotic and develop resistant strains. So when push comes to shove, what are the recommended antibiotics for an endodontic infection and their relative resistance? Use narrow-spectrum antibiotics like Pen-V or amoxicillin as first-line treatments. Amoxicillin is preferred due to its better absorption and lower risk of gastrointestinal side effects. For penicillin allergic patients, clindamycin is recommended despite its higher risk of C. difficile infection. Resistance to these, though, is a growing concern. Resistance to Pen V is relatively low, but not negligible, and an 85% susceptibility rate was found among bacteria isolated from endodontic abscesses. Resistance can be higher in specific bacterial populations, such as Viridam's group Streptococci, where resistant rates can range from 13 to 50%. Amoxicillin generally shows a higher susceptibility rate. Baumgartner and Gier found a 91% susceptibility rate for amoxicillin. However, resistance can still occur, particularly in E. faecalis, which is a common pathogen in secondary resistant endodontic infections. Recent studies indicate E. faecalis shows a little resistance to amoxicillin, but resistance can develop over time. Clindamycin resistance is more concerning. Skukate et al. Reported a 73.8% susceptibility rate for clindamycin among endodontic pathogens, with all E. faecalis isolates being resistant. Additionally, clindamycin resistance rates in anaerobic bacteria isolated from endodontic infections have been increasing over time. The FDA also notes that clindamycin resistance is often due to modification of the ribosomal RNA, leading to cross-resistance with other antibiotics like macrolides. So if you find yourself with an endodontic infection that is not responding to the first-line antibiotics, consider these following options. Coamoxiclav or Augmentin, a mixture of amoxicillin and clavulanic acid, is effective against a broad spectrum of bacteria, including those producing beta-lactamase, which can confer resistance to penicillin and amoxicillin alone. The ADA suggests using 725 milligrams 3 times a day for 7 days as a second-line treatment. Moxifloxacin has shown high in vitro activity against odontogenic bacteria, including those resistant to clindamycin and penicillin. Clinical studies have demonstrated its efficacy in treating odontogenic abscesses and inflammatory infiltrates. However, it carries a US Food and Drug Administration black box warning for serious safety hazards, so it should be used with caution. Metronidazole, used in combination with the first-line treatments, will enhance efficacy, particularly against gram-negative anaerobic organisms. The ADA recommends complementing first-line treatment with oral metronidazole 500 milligrams 3 times a day for 7 days in cases where patients do not respond promptly to initial therapy. Azithromycin can be considered for patients with a history of penicillin allergy. The ADA suggests a loading dose of 500 milligrams on day 1, followed by 250 milligrams for an additional 4 days. Increasing awareness and adherence to antibiotic prescribing guidelines among dental practitioners is necessary. Studies have shown that a significant proportion of general dental practitioners are not fully aware of these guidelines, leading to inappropriate antibiotic use. Key strategies would include primary treatment focused to prioritize operative interventions to manage infections without systemic involvement, to prescribe antibiotics only when there is evidence of systemic involvement, fever, lymphadenopathy, or in patients with compromised immunity. Use narrow-spectrum antibiotics like Pen V or amoxicillin as first-line treatments. For penicillin-allergic patients, clindamycin is recommended. At the Academy, we provide patients with precautionary prescriptions for suitable antibiotics in case they experience the 10 to 15% incidence of post-operative flare-up. They are carefully explained that it should only be taken after phoning and talking to one of our specialists. Finally, please avoid prescribing antibiotics empirically for conditions such as symptomatic irreversible pulpitis and necrotic pulps. This really is unacceptable. By following these strategies, dental practitioners can effectively manage antibiotic resistance in endodontic treatments, ensuring antibiotics remain effective for future use in future generations.